Before we dive into the nitty-gritty of newborn hyperbilirubinemia, let me define some terms you will frequently hear in this video. The first one is jaundice, which is the yellowing of the skin. Bilirubin is a yellow pigment formed from the breakdown of red blood cells. Red blood cell is the other term for erythrocyte, which gives the blood the red color and contains hemoglobin. Hemolysis is the destruction of red blood cells. Hyperbilirubinemia simply means hyper, too much or excessive, bilirubin, the product from the breakdown of red blood cells, and emia means in the blood. According to the literature, more than 80% of newborns will show yellowing of the skin after birth. So it is very common to see jaundice in newborns. Why is that? Physiologically speaking, babies have specific characteristics which makes their bilirubin level higher than the adults. Let's dive further into it. The first one is red blood cells. Newborns have higher red blood cell count or erythrocytes with shorter lifespan. In comparison, here is an estimated number in different stages of life. In adults, the lifespan of red blood cells is 120 days, in newborns 60 to 90 days, and preemies 35 to 50 days. So the faster the red blood cells die, the faster the bilirubin is formed. That being said, preemies are at the greatest risk of hyperbilirubinemia. 2. The liver, the organ responsible for metabolizing bilirubin, is still immature in newborns. Therefore, it is not effective in doing its job. And that job is removing unconjugated bilirubin in the blood. Hence, if that doesn't happen, guess what? More bilirubin remains in the body. Third, one way to remove the bilirubin from the baby's body is through pooping. If the newborn is exclusively breastfed, pay attention to the frequency of feeding. Of course, if the baby is not getting enough food, there will be less meconium stool as well. So what happens? More bilirubin will be retained in the body. It is reabsorbed in the intestines and goes back to the circulation, worsening the jaundice in newborns. Let me repeat, instead of it being excreted or eliminated, the bilirubin is reabsorbed. There are other reasons beyond what I just mentioned why hyperbilirubinemia in newborns exists. Let me give you a quick overview of some pathologic causes of hyperbilirubinemia. Just a heads up, some of these terms are complex medical terms. You don't need to dissect each one. But what I'm going to share is good information and take it as it is. If your baby has any of these conditions, please refer to the baby's provider for further explanation. Here are 4 reasons why your baby might have hyperbilirubinemia. First one is the process of hemolysis. Under this reason, there is ABO-RH incompatibility. This means if mom has a blood type O and the baby has blood type A, B, or AB, there is ABO incompatibility. If mom has an Rh negative antibody and the baby has an Rh positive antibody, this is called Rh incompatibility. Also included are disorders like G6PD, Pyruvic kinase deficiency, thalassemia, and metabolic screening tests done and sent after 24 hours of life. Second one is a non-hemolytic process. Examples are when the newborn has a traumatic delivery, resulting in cephalhematoma, subgaleal hematoma, and bruising of the face or the head. Polycythemia or high hematocrit levels, this happens for several reasons. On one of them is delayed cord clamping. There are other non-hemolytic causes as well, such as cystic fibrosis, Hirschsprung disease, and pyloric stenosis. Third one is the decreased concentration of bilirubin. These are probably the most common reasons for hyperbilirubinemia. Let me divide it into 3 types. A. Physiologic hyperbilirubinemia. The baby's liver is still immature to conjugate the bilirubin. The bilirubin, by the way, peaks on day 3 and declines over the week. Second, breastfeeding jaundice. Babies who don't get enough feeding for the first few days due to insufficient frequency and decreased volume, resulting in dehydration and increased reabsorption of bilirubin in the intestines. Why? If there is nothing that comes in, there is nothing to come out. If you eat a lot, you poop a lot too. The third one is breastmilk jaundice. This usually occurs in the 2nd week of life. It is the breast milk itself causing hyperbilirubinemia, and the exact cause is unknown. But it is believed that there are substances in the breast milk that hinders the metabolism of bilirubin. And 4, impaired bilirubin excretion, and this might due to some infection or sepsis, chromosomal abnormality, some obstruction in the biliary tract, and other metabolic disorders. Some babies are at higher risk for hyperbilirubinemia than the others. If they are born prematurely, if they have an older sibling who has hyperbilirubinemia when they are babies, and if they belong to an East Asian ethnic group. So how would you know if your baby has hyperbilirubinemia? The obvious sign is yellowing of the skin and the eyes as well. So you want to press one of your fingers on your baby's skin, starting on the face. And when you do this, as your finger applies pressure on the skin, the color will change and will show yellowing if the baby has jaundice. For the eyes, you simply look at the white of the baby's eyes and see if it looks yellow or normal white. It is not unusual for the baby's face to have a yellow tint. If you remember, a huge percentage of newborns get jaundice. You can tell if it is worsening if the yellowing spreads downwards from the head down towards the feet, or what we call cephalocaudal. If the baby's whole body is yellow, that is not a good sign. But this is not an accurate way of telling the severity of the hyperbilirubinemia. In the hospital, the nurse uses a device called transcutaneous bilirubin to measure the level of the total bilirubin at 24 hours of life, or earlier if jaundice is significant. This test is very simple, non-invasive, and done at the bedside. It gives an estimate of the total bilirubin level. Now, since it is an estimate, and if the number obtained is higher than what is expected at whatever age the newborn is in hours, a serum bilirubin is warranted, meaning blood needs to be drawn and sent to the lab for analysis. This is the most accurate way of measuring the total bilirubin level. Once the result comes back, it will be plotted on a nomogram to determine if it is a safe number or not. Other factors to consider are the baby's age at the time of the testing, gestational age, and risk factors. The nomogram guides the provider to decide the plan of care for the baby. While in the hospital, if your newborn is diagnosed with hyperbilirubinemia, the treatment modality includes phototherapy or exchange transfusion. The more common one is the phototherapy, where the baby is exposed under a blue light for several hours. The baby wears an eye shield to protect the eyes and a diaper only to expose as much of the skin as possible to the blue lights. Feeding the baby adequately in frequency and amount plays a huge part in the treatment. The type of medical management depends on the existing risk factors and the severity of the level of the bilirubin at a certain age. Now, this video is not about this specific management, but I just want to mention them so you will have an idea of what kind of treatment they do at the hospital. What this video really is about is understanding what causes jaundice, and if your newborn has elevated levels that needs close monitoring, what can you do at home to make sure it doesn't get worse? Avoid hospital readmission, and more importantly, avoid serious complications like acute bilirubin encephalopathy, where you will see signs and symptoms like increased muscle tone, arching of the back, high-pitched cry, and fever, among others, and kernicterus or brain damage. So let's talk about the highlights and must-dos if your baby is discharged from the hospital and has a borderline level of bilirubin. Now, don't worry. If the numbers are high enough that the doctors are concerned, they will not let your baby go home from the hospital. The treatment will start immediately, and the levels are closely monitored by sending serum bilirubin levels on a more frequent interval. If the doctor decides it is safe for your baby to be discharged, remember this pro tip. The bilirubin peaks on day 3 to 4, so be conscientious on your actions to prevent worsening jaundice. Let's talk about it. First, follow up with a pediatrician is very important. Before going home from the hospital, usually on the day of, the nurse will obtain a discharge bilirubin level. It could be a transcutaneous or a serum, the blood draw, to determine the next step of action. If your baby is clear, the nurse will give you instructions when to follow up with your pediatrician. Obviously, if there's a concern, they want your baby to be seen the next day, so you need to call and make an appointment for the next day. Don't forget to bring the baby's discharge paperwork to the follow-up visit because the clinical summary, including the bilirubin level at the time of discharge, is there. So, what if it's the weekend and the doctor's office is closed? Well, normally you will be asked to bring your baby back to the hospital for a bilirubin check. Second, if you remember from the earlier part of this video, one of the reasons why the bilirubin is elevated is that the baby is not getting enough feeding, especially if it is a breastfed baby. Not all babies are great breastfeeders, and not all moms are experienced with breastfeeding. Therefore, it is very important to establish good breastfeeding habits from day one, as soon as after your baby is born. Learn everything you can about breastfeeding before delivery and apply what you learn minutes after your baby is born. Learn how to manually express breast milk, how to increase your milk supply, how to get the ideal breastfeeding position, how to get the perfect latch, and so on and so forth. Make sure the baby is getting enough calories and make it a goal to prevent dehydration. Know the signs of dehydration like dry mouth and lips, sunken eyeballs, decreased number of wet diapers, dark colored urine, and excessive weight loss. Seek the help of the nurses and especially the lactation consultants while at the hospital. They will be your best resource and allies to successful breastfeeding. You need to breastfeed 8 to 12 times in 24 hours. It doesn't matter what the timing is as long as you are not letting your baby sleep for more than 4 hours. Do a lot of skin to skin. You can cluster feed if your baby wants to. Breastfeed as often as you can. If the baby is getting enough breast milk, passing meconium stools will be achieved. The more poop, the better. Bilirubin is excreted out of the body through pooping. I cannot stress this more than enough. Breastfeeding jaundice happens because of inadequate feeding. Now, babies who are bottle fed with formula have a lesser risk for hyperbilirubinemia. Well, as long as the baby is fed every 3 hours with adequate volume of formula. Don't let your baby sleep for more than 4 hours without feeding. Definitely monitor the number of poops too. The more poop, the better. But please do not misinterpret this information that formula-fed babies are better off. The benefits of breastfeeding definitely outweighs the risk. Let me touch on breastmilk jaundice. This is different from breastfeeding jaundice. Breastmilk jaundice appears on the baby's second week of life. The mechanism cannot be fully explained, but some components of breast milk contribute to the inefficient metabolism of bilirubin. In this case, your pediatrician will advise you what to do. And if that requires you to temporarily supplement with formula, please seek the advice of a lactation consultant to see how to manage breastfeeding and maintain your milk supply. Unfortunately, interrupted breastfeeding usually results in cessation of breastfeeding. You don't want that. You want to breastfeed at least until your baby is 6 months old. The third one, know the signs and symptoms to report to the pediatrician. Monitoring the jaundice, making sure it is not evident on the whole body. What I mean by that is, if the yellowing of the skin extends from the head down to the feet, it is not a good sign. Check the chest, abdomen, arms, and legs. Sit next to a window because it has better lighting, and look at your baby's skin. You can use the finger pressure. Please reference the earlier part of this video where I mentioned the process of doing it. Call a doctor if your baby is not feeding well, has poor suck, skipping feedings, lethargic, has poor muscle tone, behaving or acting abnormally, not their usual self. And if you have a feeling that something is not right, trust your instincts. If your baby doesn't wake up or is difficult to rouse, please call 911. Remember, parents, if you have any concerns at all, your pediatrician is just a call away. Please don't hesitate to reach out to them because they are your partners in making sure your baby is at the optimum level of health. Now, moms and dads, does this information help make you feel a little better? Let me know in the comments if you gain more clarity on how to take care of your baby who has hyperbilirubinemia. Alright, I hope you got a lot of value from our video today. Please click subscribe button if you have not yet joined our community. Be well everyone, make this day count, and happy watching!